Kim, you can please go ahead and start the event.
Thank you. Good morning, good day, good evening, everyone. Welcome. Thank you so much for joining us today as part of this webinar, which is titled The COVID-19 Public Health Emergency, Sharing New York City's Response. My name is Dr. Kim Knowlton. I'm a health scientist and senior scientist with the Natural Resources Defense Council in New York City and deputy director of our science center. It is my privilege at NRDC to work with our India team and with wonderful partners in Ahmedabad and other cities in India for the last 10 years. It's also a great privilege to have colleagues, excellent colleagues, at the New York City Department of Health and Mental Hygiene, who all helped us put together this conversation on the terrible COVID-19 public health emergency, which is truly a global crisis. Our deep thanks go to everyone at New York City Department of Health and Mental Hygiene, in addition to Dr. Chokshi, who I will soon introduce. Also thanks to Robert Fuller, to Adriana Joseph, Nellie Asfar, Katie Lane, Munira Ahmed at NRDC, my colleagues Samir Quatra, Amanda Maxwell, Prima Madan, Kriti Segal, Vijay Lamai, and to everyone at IIPHG who has made this possible, from Dr. Dileep Mavalankar, who you will soon meet and who had the idea to request this meeting, to Dr. Apurva, who you will meet during a question and answer session. To set the stage a little bit, a year ago in May 2020, as the first wave of the coronavirus pandemic was sweeping the globe, NRDC helped to convene a similar conference call between the public health colleagues from New York City and from the city of Ahmedabad in Gujarat in Western India, the state there, all know. And in 2015, New York City DOH staff met previously with colleagues from IIPHG and other India colleagues as part of what we called a knowledge exchange forum. So there's been a chance to have conversations around a number of public health topics. But now, a year later, with India contending with the second wave of COVID-19, we wanted to help again to organize this, which will be a 90-minute webinar among New York City and Ahmedabad public health community colleagues, with a moderated conversation that I will help with, followed by time for audience question and answer. And this event is being recorded for sharing later. So just to run quickly through the logistics after this introduction of two esteemed speakers, Dr. Chokshi and Mavalankar. Dr. Mavalankar will provide some background, setting the stage on the India epidemic scene. Then I will moderate about 30 minutes of a conversation between Drs. Chokshi and Mavalankar with some specific questions, a focused discussion between the two gentlemen. And after the moderated panel, you participants will be able to ask questions of the speakers. There were over 100 participants registered. Everyone is on auto mute, so we ask, please, during the Q&A, that you type your questions into the chat function on the far right of your Blue Jeans screen. And NRDC team members will then provide those questions to our IIPHG colleague, who will moderate that portion. And please do say which of the speakers your question is for if you offer a question into the Q&A. So those are the kind of the background here. It is now my honor to introduce our two people who will be speaking, two colleagues. First, Dr. Dileep Mavalankar, who is director of the Indian Institute of Public Health in Gandhinagar. Professor Mavalankar has been heading the Indian Institute of Public Health in Gandhinagar as director since 2012. He received an MB, BS, and MD in preventive and social medicine from Gujarat University in Ahmedabad, an MPH and DRPH from the Johns Hopkins School of Hygiene and Public Health in the U.S. His work experience includes faculty and research positions in NHL Municipal Medical College in Ahmedabad, in the National Institute of Health in Bethesda, Maryland, USA, the Indian Institute of Management in Ahmedabad, India, and the Mailman School of Public Health at Columbia University in New York City. Dr. Mavalankar is actively involved in research focused on improving management of EMOC in rural hospitals, in strengthening reproductive health implications for program management, in improving quality of care in family welfare, including maternal health and health policy analysis. He also works on health and family planning, government and NGO collaboration in health programs, and management of service sector and quality of services. Dr. Mavalankar, thank you for your inspiration in getting this conversation together, sir. And second, I would like to introduce Dr. Dave Chokshi, Commissioner of the New York City Department of Health and Mental Hygiene. Dr. Chokshi is commissioner of that agency and most recently served as Chief Population Health Officer at New York City Health and Hospitals, where he built and grew an award-winning team dedicated to health system improvement, spanning innovative care models and analytics, primary care transformation, social determinants of health, community-based care management, and chronic diseases and prevention. He has taken care of patients as a primary care physician at Bellevue Hospital since 2014. Dr. Chokshi's prior work experience spans the public, private, and nonprofit sectors, including positions with the New York City and state departments of health and the Louisiana Department of Health before and after Hurricane Katrina. Dr. Chokshi served on the FEMA delegation to New York City after Hurricane Sandy in 2012. He also served as White House Fellow and was the Principal Health Advisor to the Secretary of Veterans Affairs. Dr. Chokshi has written widely on public health and medicine in the New England Journal of Medicine, JAMA, The Lancet, Health Affairs, Science, and Scientific American. In 2016, President Obama appointed him to the Advisory Group on Prevention, Health Promotion, and Integrative and Public Health. He trained in internal medicine at Brigham and Women's Hospital, receiving the Dunn Award for Compassionate Care, and was a clinical fellow at Harvard Medical School. Dr. Chokshi also earned an MSc in Global Public Health as a Rhodes Scholar at Oxford and graduated summa cum laude from Duke University. Gentlemen, thank you so much for being here with us today. We'll have a chance to hear from you both more in a moment and you to speak with one another. But for now, Dr. Mavalankar, would you be so kind as to provide a brief background on both IIPHG, where you are director, and on the current Indian epidemic scene? Thank you, sir. The floor is yours.
Thank you very much, Kim Knowlton. I hope you can hear me well. At the outset, let me thank NRDC team to organize this webinar with the New York City Health Department. And you have been so kind enough to organize similar webinar just 1 year ago when this whole disease was new. So we thought that after 1 year's experience, we should still learn about the second wave immunization and other issues which New York City and the US in general have handled. And we have this unexpected second wave, which is very, very terrible, as you have been seeing on international media. So first of all, thanks to the Health Commissioner of New York, Dr. Chokshi, and his whole team for sparing his valuable time. I will take 2 minutes to introduce my institute. Indian Institute of Public Health, Gandhinagar, is a public-private partnership between the state government of Gujarat and Public Health Foundation of India, which is a national foundation set up in 2006-07 to promote public health education, research, and training in India. Our institute was set up in 2008 as an autonomous institute in the western part of India, in the city of Gandhinagar, which is the capital of Gujarat state. We offer Master of Public Health and Master of Hospital Administration programs and postgraduate program in Public Health Management, as well as we offer a 3-month program for industrial health for physicians who work in factories as industrial health physicians. We also do research and support the government in all its public health work, as well as we have been working very closely with the state government during this pandemic of COVID-19. We have a small faculty of 16 full-time faculty members and several adjunct faculty, as well as more than 50 research staff. Our faculty spends half of their time on research and roughly half on teaching the students. Currently, we have about 200 postgraduate students between all our programs. With that introduction of the IIPH, let me move to the experience of India in this pandemic. And many of you know well, we had a national lockdown from 24th of March 2020 to almost end of May 2020. And following that, there was gradual opening up of the economy. And because of the lockdown, we had a very low number of cases, which gradually built up as the economy opened. And we have a national peak of daily cases of about 100,000 per day in mid-September last year. Following that, several measures were taken and community also started wearing masks, maintaining social distance, and interactions were minimized through various mechanisms, as well as public health mechanisms of early diagnosis, tracking, and tracing of the cases. The epidemic started to wane nationally, and gradually it came down to only 8,000 cases, from 100,000 cases per day to 8,000 cases in mid of February 2021. And everybody thought that we will have a very rapid decline further and the pandemic will go away. But since the middle of March, cases started increasing, especially in the state of Maharashtra and Kerala and Punjab, and also gradually in many other states. And by end of April, we reached 400,000 cases daily reported, which is 4 times the size of the previous first wave peak. And almost impossible situations happened in all the hospitals, almost everywhere. There was nowhere any patient could be admitted. There was no room in emergency rooms, in ventilators were full. All kinds of COVID beds were full. Patients were compulsorily had to be treated at home with oxygen and many other invasive therapies at home. So it was very, very unprecedented times. And I must say my hats off to our health colleagues and hospital doctors as well as hospital staff who have tirelessly managed this second peak. And fortunately now, for last 10 days, we have some indication, at least in my state, also in the neighboring state of Maharashtra and some states, that the cases are coming down. Of course, we started with vaccination in middle of January. Initially, the doctors, nurses, and health workers were vaccinated, and later on, the police and other government frontline workers who interact with the community were also vaccinated. And from 1st March, they started vaccinating elderly people above 60 and later on above 45. And now from 1st of May, we have vaccination for everybody above 18 years of age. So along with vaccination moving, we are now moving in a phase where we hope that this second and very tragic peak will go down. But we thought that with that, we should also learn lessons from wherever possible. And New York is the best place as they have managed the first peak with very great difficulty, but second peak probably much better. What we can learn from there may not be immediately applicable as in India, but we can definitely learn lessons, exchange notes, and the principles which they used would be very useful. We recently had a meeting of the core committee of the state with the chief minister, and he has given us the task to prepare for a third wave. We hope it will not come, but if it comes, his vision is that we should be prepared for a third wave, which is double the size of the second wave. So it is really a tall order for the state to prepare all the medical services as well as public health services to meet with what is called as tsunami, the double size tsunami of the third wave, which may happen after 3 months. So that's where we thought that we would learn from all parts of the world as well as from the states of India. And that is why this was the first webinar out of this series of webinars we plan to organize in next month or so. So that is the background. Let me not take much time because we are all eager to hear from the Commissioner, Dr. Chokshi, about New York's experience. Thank you very much, Kim, again, and thank you, Dr. Chokshi and his team.
Thank you, Dr. Mavalankar. Very gracious to offer that view and those insights. And indeed, Dr. Chokshi, we're so grateful that you're here. Dr. Mavalankar was helpful in kind of framing a handful of questions to begin your conversation. So if I may, I'm going to share the first one, but of course, you are the two experts. Feel free to take the conversation where it needs to address the questions. I guess the first question was, it's a two-parter. The first part being, Dr. Chokshi, a brief summary of your view of in the U.S., like nationally, what was the way of contending with the second wave of COVID-19? What were the lessons learned broadly? And then preview, the second question is going to be, how in New York City did you help to manage the second wave and the lessons learned? If there are insights about the national and the city scale, I know everyone would be very interested to hear. Thank you, sir. The floor is yours.
Thank you so much. And let me also just add my gratitude to NRDC, to you, Kim, and to all of the organizers for the event today. It's one that I've been really looking forward to because it feels like a small way, that we can help and demonstrate solidarity and really pay it forward because, I remember the dark days that we experienced last March and April all too well. And we had help from all corners of not just the country, but from all around the world. And, connected with colleagues to share notes on what we all remember was a very fast-moving and terrifying time with respect to the beginning of the coronavirus pandemic. I also want to even though my biography I know was too long, so I apologize for everyone having to sit through that. But there's one piece that I did want to mention, which is, obviously I think you can tell that I'm of Indian descent, of South Asian descent. But I wanted to specifically mention that most of my extended family is in Mumbai, in Maharashtra right now. And so, not just the media reports, but also hearing from family members about their struggles and difficulties, and many of my own family members who have gotten sick, makes it very personal for me. And even though there in Mumbai, we are of Gujarati background, so my parents are both Gujarati, and I spent some time in medical school in Baroda in Gujarat, actually at the Sri Sayaji Rao General Hospital for Dr. Mavalankar, and I'm sure many others who know that is a key public hospital for that region in Gujarat. So it's all to say I have an ability to visualize what you're going through by combining my experience in New York City with those prior experiences and personal experiences as well. And so let me just answer your question a little bit more directly, Kim, to say to accompany Dr. Mavalankar's description of the pandemic in India with what we have experienced in New York City, which was characterized by a very rapid ascent of our first peak in February and March of 2020. I remember all too vividly what that felt like. I was working at the public hospital system here in New York at the time, and we went from the first confirmed case being diagnosed in early March to, unfortunately, our first confirmed death just 2 weeks later in the middle of March, and then an extremely steep trajectory of cases and hospitalizations and deaths over the subsequent weeks. We also, as you described, we had a stay-at-home order, a lockdown that went into effect in around that time frame, middle of March through early May. And that helped us get the first wave under control, although not without pushing our healthcare system to the very brink. And I think the other thing that I really remember from that time was it was only, by the grace of a higher power that we didn't have our hospital system collapse due to the burden of disease that we were seeing. So I think that's the backdrop that one has to understand, when we talk about our approaches to COVID in the wake of that first wave. We emerged from it really, end of May, beginning of June. And that's when we geared up, knowing, of course, that we didn't have the tool of vaccination at that point, that we were going to have to rely on our public health measures to be able to prevent or at least mitigate the future resurgence that we did expect, for, if not the summer of last year, certainly in the fall and winter. And our approach, really revolved around a handful of things. One was what we and many others call the core four, the major tools that we have, given the characteristics of the coronavirus, of any respiratory virus of this type, which boils down to space, time, and source control. And so, tangibly, that meant we looked at encouraging mask use, encouraging physical distancing, making sure that people were staying home if they were feeling ill, and hand washing as well. And it was those, bread and butter tactics that we sought to make pervasive in society. And I think in retrospect, it feels like something that was very natural and easy, but it was actually a landmark shift, both in terms of our public communication, as well as, how all of our routines baked in those, those core public health tools. Layered on top of that were some of the other public health tactics that the Dean has already described, particularly building out our testing and tracing apparatus. We invested a huge amount of resources in being able to make testing widely available. We were one of the certainly the national leaders and also world leaders in testing done per capita, starting in June and July of last year when it became more feasible to do wide-scale testing. But we knew that testing alone was not sufficient. So we matched it up with one of the largest contact tracing apparatuses that existed, known as our Test and Trace Core. We hired hundreds of staff members to be able to do that, within a span of weeks. And so we linked together that massive expansion of testing with our contact tracing as well. Ultimately, as I'm sure many of you are familiar, even testing and tracing is not sufficient. It boils down to effectiveness of isolation and quarantine. And so we focused a lot on supporting people with the resources that they needed to isolate and quarantine in a timely fashion. Just a couple of specific examples. We looked very hard at our test turnaround times as a key metric, because we knew that if we were able to shrink that down from the 4 to 5 days that it was at the beginning, of our testing expansion, down to the 24 to 48 hours where it is right now, that would really enable us to have more timely isolation for cases. The other piece of it was what we call resource navigation, which is just a phrase for making sure that people were connected to the ability to isolate or quarantine very quickly. We had hotel rooms that were available for people who wanted to isolate or quarantine away from their families. And we set up resource navigators, with the specific purpose of asking people what they needed to effectively isolate, whether it was masks, whether it was food, whether it was shelter, really focusing on that part of it. One note that I'll make that I think was a lesson learned for us is that, almost a year later, we've learned that household transmission is such a key part of the way that the coronavirus spreads. And all of the tools that I described were only somewhat effective for mitigating household transmission. And that's an area where we have to continue to work and improve our methods, knowing that we don't live in an authoritarian society. We can't do what has been done in some Asian countries, which essentially mandates isolation and quarantine. And so that limits our ability to use tools to limit the spread within households, but potentially is an area for creativity. The final thing that I'll say, so as not to go on too long in my answer, is that we also married up all of those public health tools that I described with a real linkage to the healthcare system. We saw back in March and April how important it was for us to work with our healthcare colleagues, just very tangibly, because the efficacy of physical distancing translated into how many people were showing up in our intensive care units or emergency departments, as of course I know you are experiencing right now. And so we strove to tear down the barriers that exist between public health and healthcare, which I'm not sure exactly how much of that is true in India and particularly Gujarat, but it was true, for us in New York City, where public health and healthcare were not as linked up as we needed to be. And so, that was an area where we worked very quickly in real time during the first phase of pandemic response, and that has borne, a lot of fruit going forward as well. I think about it from the perspective of the average, the layperson. They don't really know the difference between public health and healthcare delivery. They just expect people to do the things that we should be doing to protect and preserve health, either from prevention or when someone is in extremis and really needs, more urgent support. And so we have taken it as our jobs to work together behind the scenes to make that a much more seamless experience. So I hope that's a useful survey, and I'll turn it back to you, Kim.
Thank you, Dr. Chokshi. That's really illuminates so many points. Dr. Mavalankar, did you want to respond to any of the details that Dr. Chokshi put forth, or to that interesting point about barriers that do exist quite commonly between public health and healthcare delivery, and how it's quite useful in a situation like the pandemic to try and minimize those? If there's anything you want to engage with one another on, please take that.
I want to pick up on 2 points which he highlighted, which are very, very important. First was resource and resource negotiation and making resources available to the public wherever needed. So I think that's an important function, because there is so much of disruption which happens this kind of a pandemic, and especially in some of the parts of India, and we also saw here. One is the fear, because it's a new disease. Second is stigma, that it is highly infectious, so people want to keep away from their friends, relatives, even within the family, and the kind of guilt which people develop once they get infected. So all of that, besides the physical part of health, the mental part of health, and the public health implications are also, I think, important. Second, I think, is a point which he mentioned, which I want to highlight, which we are seeing here now, the difference in the first and second wave. We have done studies to show that the intra-house transmission, secondary attack rates within the families were quite low in the first phase of the pandemic, which were about 10% to 20%, not so high. But in the second wave, it seems that almost all families have many, many cases. So within the family, transmission has dramatically changed. Of course, we have not yet finished. We have just started thinking about studies in the family transmission and how transmission happens, how to prevent it, etc. So that's an important dimension. We must all understand that besides stopping transmission outside the home, how do we stop transmission as much as possible within the home? So I think that is an important point he also raised. One other issue which I would like to also flag, and maybe he can talk about, Dr. Chokshi, is what happens to the regular health services in such a major pandemic, where all health resources and public health resources, almost 90%, are devoted to the meeting the challenges of the pandemic. So what happens to those who develop heart disease or heart attack, stroke, or any major injury or any other regular problems, and how they were tackled, and what kind of challenges that raises in such a time when most of the health resources are devoted to fighting the pandemic. Thank you.
Thank you. I'm happy to speak to that, Kim, but I'll defer to you if you want to moderate us.
Please do. We have until like 15 more minutes in this portion, and this is so important. So feel free to engage with one another. I'll jump in gracefully with the next couple questions in a few minutes.
Perfect. Well, I'll be brief in my response, but I'm very grateful that you are raising this important issue, Dr. Mavalankar, because we saw during the first wave in New York City, we saw the reverberating effects on other conditions, that were in many cases as impactful as the direct effects of COVID-19. I'll just mention my team at the public hospital system here. We published a study in New England Journal of Medicine, the New England Journal of Medicine Catalyst, around X curves. And X curves, I'll just show you visually. This is what I mean by an X curve, where the ascent of, for example, ICU admissions due to COVID-19 was paired with a descent of ICU admissions for any other cause of illness. And we focused on ICU admissions and looking at this particularly because one would expect that those were things that were less volitional. less selective, whether it's strokes or heart attacks, or sepsis. But in fact, we found there was a marked decline, in ICU admissions due to other causes. So that's just an example of how even in the ICU, but particularly for less acute, medical care, routine care for hypertension and diabetes and all of the other things that we know matter to avoid, more serious complications. Pediatric immunizations, all of those were blunted, were significantly affected due to COVID-19. So it's one thing to characterize it. It's another thing to talk about what we can actually do about it. And for that, the tools that we used, a lot of it was around public communication, ensuring that people knew that medical care was an essential service. So in addition to going to the grocery store or to the market, to buy food, one should continue going to the doctor, including for routine care. As the lockdown started to be lifted, that was one of the first things that we emphasized to try to get things back on track. And my health department colleagues published a nice study showing that for pediatric immunizations, although there was a significant dip in March and April, we were able to get it back on track by June. So those are the key things that we looked at. The final point that I'll make on this, because I do think, again, you start to get tunnel vision when you're so focused on the direct effects of the pandemic, as you are right now, just given the burden of disease that you're seeing in India. But we know that it's those concentric circles of health effects, the effect on other diseases as we just talked about, but also the effects on the social factors that make the greatest difference for the health of indigent people, for the health of marginalized populations, food and shelter, and making sure that people have enough money, to meet their basic needs. Those were all things that we strove to have a broad lens of our responsibility, working, with other government partners to ensure that some of those reverberating effects were mitigated as well.
Thanks, Dr. Chokshi. Dr. Mavalankar, anything else to add or question on that series of questions, or do you want to go on to the next one?
Oh, I think we can go to the next one.
Okay, thank you. A question about how is New York City managing its vaccination program now?
Well, thanks so much. I'll give the brief survey, and then I'm happy to dive into the things that feel like they would be most germane, for your situation. We embarked on our vaccination campaign in the middle of December, of 2020. We've now administered 7 million doses of vaccine to our population. Just a reminder, we have about 8.5 million people in New York City. So 7 million doses administered. We're approaching 3.5 million people who have gotten at least one dose, and a little bit over 2.5 million who are fully vaccinated. So it's been going reasonably well overall. We have, focused on a few pillars in our vaccination campaign. At the individual level, communicating that it is safe, the vaccine is free, for everyone, and we've sought to make it easy for people to actually get vaccinated by expanding access points as broadly as possible. And then for the campaign as a whole, our tagline has been that we want it to be, again, safe, because that is always so critical in communicating for people to make their decision about vaccination, but also swift. We really focused on making sure that, particularly in the earlier stages of the campaign, as soon as we had supply of vaccine delivered to New York City, we had the capacity, the infrastructure to administer all of it, essentially within 7 days of receipt, into the city. And then the final part of it is equitable. This has been in many ways the most challenging aspect of our vaccination campaign, because the more affluent And in New York City, the white population compared to racial and ethnic minorities were more likely to get vaccinated sooner. And so from the very beginning, we baked in the desire and the strategy, to have equity be a fundamental way that we were measuring and holding ourselves accountable for success. So much of this derives from the data that we are tracking, in terms of having the geographic spread of vaccination. We measure vaccination rates by zip code, in your case by postal code. Within New York City, we measure vaccination rates by race and ethnicity, and we also track it by the vulnerability indices that help us, bundle together various social factors. So that's kind of the overall view. I think the other thing that I will mention is that we are now in the phase of our vaccination campaign where the early adopters, the people who really wanted to get vaccinated, have been vaccinated. And our challenge has shifted from supply to demand, and addressing the fact that we have to do more to inform and persuade and even further lower barriers to access so that, the remaining population chooses vaccination to try to get to higher levels of vaccination. We're approaching 60% of the population with at least one dose, across New York City, and our goal is to get to above 70% over the course of the summer.
That is lovely. One point I thought I'll quickly ask you, because what is happening in India is that given the size of the country, we will require roughly 2 billion doses of vaccine, whatever vaccine available, to vaccinate everybody above 18 years of age. And that is where India is really very eagerly looking for importing now vaccine. We have large vaccine manufacturers, but they will not be able to manufacture enough vaccine. And my question was, did you had great difficulty in ramping up the cold chain equipment? Because the Pfizer vaccine requires -70 degrees and Moderna requires -20 degrees, which normally in our vaccination systems, we don't have vaccines of that type as of now. So one of the issues India is struggling with is what kind of cold chain will be required if we get really imported vaccines from Pfizer and Moderna. So some things on that would be useful.
Yes, thank you. This is a very important question, and I certainly understand that your logistical obstacles are much more significant, than ours, given the existing infrastructure that is here in New York City. For us, we relied a lot, particularly for Pfizer, given the ultra cold storage requirements on our hospitals. They were the initial places where we placed Pfizer, and they became, the hubs for administration of Pfizer vaccine. Moderna, we've been able to, use portable freezers and really get more to the spoke, in the hub and spoke model using Moderna. And so I think that, I would be more optimistic about that. I'll also just point out, I'm sure but for your colleagues as well, both Pfizer and Moderna, can be stored either at freezer temperature or refrigerator temperature, for a certain period of time. And so if you're able to organize the volume of the operation such that, you use the vaccine within the span of days, that does open up considerable flexibility with respect to the cold chain. So those are, I think, the salient points that come to mind. I'll also just point out we are using the Johnson & Johnson vaccine as well, and that's, of course, the most flexible. That's what we've used. We have, mobile vaccine buses and vans that go out into neighborhoods. We have We have a homebound vaccination program to get to people who are unable to leave their homes. A lot of that is actually run by our fire department colleagues because they have the logistical capacity, to actually be able to enter into people's homes, particularly the emergency medical technicians within our fire department. And the Johnson & Johnson vaccine has given us the flexibility that we need to be able to do that.
Wow.
Next issue would be how do we deal, or how did you deal with the adverse effect following vaccination, and did you had a larger issue and the fear of that causing people to hesitate to take vaccine? So what was the experience in New York? Because here there is some section of the population is still hesitant to take vaccine because it's a new vaccine.
Yes, I mean, I'd be interested in hearing more about your experience as well, because I do think that it's of course different in different cultures and across education levels, and so I have a lot of humility about how much of our experience would transfer over to yours. But to share briefly, yes, for people who remain unvaccinated, the concern about side effects, more long-term side effects compared to short-term side effects seems to be the most common reason cited. So some of the ways that we have tried to address that are, of course, again, through public communication. I do public service announcements that are very broadly disseminated on our television channels and through social media. Really, taking the tack that the best way to address misinformation is actually by providing good information from trusted messengers, and recognizing that sometimes that's not always the government, that's actually people who are actually, living and working in communities. And so getting them to say those key, science-based points has been very important. So I summarize that as focus on the message, but almost equally, focus on the messenger. So that's one, very important tool. The second one that we've used that flows from that is to try to push more and more vaccination away from our mass sites, which were very important in the early stages of the campaign to have high volume throughput. I imagine this has been and will be important in India as well. But then getting as much vaccine into doctors' offices, into the places where people are already used to getting their care and that they already trust. For us, it's primary care doctors, it's independent pharmacies, the neighborhood pharmacies, and of course there's a logistical challenge there as well, which again I'm sure is multiplied in India. But we have felt very strongly that has to be a part of our next phase of the vaccination campaign, because people are just more likely to trust and believe, the benefits of vaccination when it's coming from someone who has been taking care of them for years.
Great points. Excuse me.
Go ahead, Kim.
Gentlemen, we have two more questions, but I also want to afford time for the participants to ask questions, and I know we have some really great ones. So I'm tempted to proceed to that interactive, you both with each other and the audience portion, the last portion of the call. And it's been a privilege for me to talk and listen with you both. So with great thanks, I'm now going to ask you to please stay right in the frame of mind you are, and I'm going to hand over to Dr. Apurva, Economic Evaluation Specialist from IIPHG, the proceedings, and Dr. Apurva is going to moderate the Q&A from the audience. Thank you very much. Dr. Apurva, the floor is yours.
Thank you, Dr. Kim, for this opportunity. We have received a couple of insightful questions. So without delay, I would like to put forth questions. So the first question is for Dr. Chokshi. The question is, any tips on how New York City helped healthcare providers get some assistance, care, relief for their own physical exhaustion and mental health concerns?
Well, this is such an important question. So I thank the person that raised it, because this was something that we experienced very catastrophically, very gravely. I remember in April of last year, in particular, I would spend time in our hospitals, in our ICUs, and emergency departments, and the scale of illness and death that was being experienced was extremely traumatizing. And it's actually very hard to explain for someone, who hasn't been in a clinical setting when you are, when you're experiencing that day in, day out. I remember some of my fellow doctors describing they would make morning rounds, and, whereas it would be an extremely unusual thing to find a patient who had passed away overnight on morning rounds, their morning rounds involved declaring, time of death for multiple patients, each day. And that is something that just wears away at your soul, and at your ability to stand strong amidst that raging storm around you. So in terms of, what we tried to do, a big part of it was providing staffing support. We had military staff, medical staff, who came in to shore up our hospitals. We, one of the things that I helped organize was ICU volunteers, critical care trained volunteers from around the country. They flew into New York City because we were experiencing it much more severely than other parts of the country during our first wave. And that made all the difference. Paying attention to personal protective equipment and, making sure that people had the PPE that they needed was both a challenge in the early days of the pandemic, but critically important, to give people the sense that we were looking out for them, and trying to keep their protection in mind as well. And the other part of it, particularly from the mental health perspective, is you may have heard, there's a program known as Second Victims, or Helping Healers Heal. And it's really about taking the time to process trauma as it's occurring. And this feels, again, extraordinarily challenging to do when you have not a spare second. You're using all of your time to actually take care of people. But we found having, hard stops, the structure for people to have a space to talk to their colleagues, to process the fact that they were seeing so much death and suffering, that was extremely important, to do. And we relied on our psychiatrists and psychologists to organize those forums and, and give people the space they needed to process in real time so that they could recharge and, at least have some, some method of coping with what was going on.
Yeah, thank you very much. We have another question for you, sir. Our participant, Dennis, has asked that could you share thoughts on the peak periods when the hospital system was overwhelmed during New York's COVID peak last year, and how that was managed?
There were some hospitals that came very close to being completely overwhelmed. None of them, quite surpassed that brink because we invested a lot of time and energy into what we call level loading. Essentially being able to shift resources around, to be able to match the demand up with supply. I'll just share, a couple of our principles on this. One was, it's always better to shift the medical resources around than to shift the patients around. So, whether it was oxygen or staff or PPE, we built the systems to be able to get as close to a real-time inventory as possible across different places. And then, when some place was running low on something, we were able to, shift things around in that way. But there were cases where, again, particularly at the height of the surge, we actually had to shift patients around as well. And so we built a system to do that. It wasn't something that existed, prior to the pandemic, but essentially, used some of our very precious emergency transport resources to shift patients around, when there were just no ventilators available, at some hospitals, or no more space in the intensive care unit or emergency departments, to shift them to other hospitals.
Thank you. We have one more question. I'm not sure for whom, but the question is, any insights on coordination, sharing, and control of medical supplies, including oxygen, equipment, and PPE? So, Dr. Chokshi, would you like to answer?
Sure. I'll answer briefly, and I'm sure Dr. Mavalankar has more applicable thoughts in the Indian context. But the one thing that I'll just build on from my previous answer is to say that in real time, in actual operations during a pandemic, it's very hard to build the systems to do this in the rigorous way that one would like. So we ended up doing a lot of phone calls and Excel spreadsheets, and just standing up the hubs, for people to communicate about their needs and have a control center to adjudicate that. It was really, sort of air traffic control, but not in that careful and methodical way, but instead just having, the corpus callosum is how I think about it, where all of those signals are converging, and you have a way to at least bring some organization to it. So I think the big point is just that, of course, you would love to have a sophisticated computer program to do this, but you have to just stand it up, put someone in charge, and let them use old-fashioned methods to make this work.
Thank you very much. Dr. Mavalankar, can you please provide your insights on this?
Going to say that this becomes even more challenging. Sure, in New York also it is similar, especially when the hospital systems are governed by different organizations. For example, in Ahmedabad, we have hospitals which belong to the city government, hospitals which belong to the state government, hospitals which are completely private on their own, and hospitals belong to trust and charitable profit. Coordinating between all of them, ensuring that everybody contributes. So see that in normal times these hospitals may be competing with each other, but in a pandemic you want them to cooperate with each other to deliver the public health benefit. So what are the issues related to this, and about billing costs of such care? Because insurance is a major provider in how do you people whose insurance are running out or who have inadequate insurance, and hospitals find that patients are not able to pay, because that is one challenge which of course challenge in India. And private hospitals are very, very high. So thoughts on that would be.
Yes, certainly. I had a hard time hearing a little bit of what you were saying, Dr. Mavalankar, but I think I caught the gist of it, which was around the links between private and public hospitals, and that includes billing considerations, since it's very difficult to use your usual systems, and that's how a lot of the revenue, particularly for private hospitals, flows. So if I captured the gist well, what I would say about it is this is an area where government has to intervene. And it sounds like you have a good, collaborative relationship with your state government, including the chief minister. But in a public health emergency, in a crisis like this, we have to think about resources in a way that is much more shared and collective than, during usual circumstances. I know that's much easier said than done. I know there are political challenges and, economic challenges to doing it. But I think the starting point for us as public health practitioners has to be that we know that we have to draw upon all of the resources, that we have available, and even then it may not be enough. And so our starting point has to be very vocal in our advocacy that, that private hospitals have to be made available, in emergent situations. And, a lot of that was done in the New York context, particularly by New York State, which actually has the regulatory authority over our hospital systems. But it's an area where, we have to have that whole of government response, where I think our role as health professionals is to sound the alarm and say, look, this is not business as usual. This is a once in a generation, hopefully once in a lifetime, once in a century pandemic. And the usual rules do not apply. They must be suspended. And I think the same thing applies to the billing considerations as well. A lot of that did fall by the wayside during the peak of our surge as well. But we did use relationships with our health insurance companies, which, by the way, overall, were not seeing as much, as many claims being made for their services because of what we talked about earlier. So many of the other health services were being underutilized. So despite the fact that, hospitals were so full due to COVID-19, health insurance companies were doing okay economically. And so that's a way that, one can petition for flexibility with respect to how they can support healthcare systems as they were on the brink of collapse.
Thank you. Dr. Chokshi, you talked about equity principle for, COVID-19 pandemic response. So one of our participants has asked, did you adopt the method of prioritizing vaccination in area where COVID cases were more in number, or the focus was more on ethnic population?
Sorry, very good question. And I think there are different approaches to this. So I don't purport to have the final answer. I think it depends a lot on local context. But our approach, there were sort of two pieces to it, which I think about as eligibility and then geography. So to take both pieces in turn, eligibility has to do with who was prioritized first, primarily due to occupation or age or medical vulnerability. So we started with healthcare workers and nursing home residents, staff, because it was the combination of vulnerability with an essential service, healthcare workers whom we knew we would need to rely upon if there were another surge. And then that eligibility broadened out, to get to older adults, to get to other essential workers, and other people who are vulnerable, such as younger adults with chronic diseases. The second part of it is geography. How did we think about prioritizing, knowing those equity considerations that I alluded to earlier? And for that, we focused on 33 areas within New York City, out of about 120, 130 or so. Those 33, about a quarter of them were the places that were hardest hit during the earlier waves of COVID-19. So it was a combination of the disease burden, during those earlier waves. But remember, and this is borne out in the Indian example as well, that burden is not happenstance. It's not coincidence. It has to do with the patterns of injustice that have been laid down over decades and centuries. Disinvestment, areas that have been lower poverty, for generations. And so we combined those health and social factors to get to, a type of vulnerability index that allowed us to prioritize, certain areas within New York City. And what we did with that priority was, it was always front and center in our mind when it comes to access. So for some of the sites that my department set up for vaccination, we prioritized those areas in terms of setting them up. We're also prioritizing providers, meaning doctors and pharmacies in those areas, to get vaccine supply earlier. So that was the way that we operationalized prioritization around both eligibility and geography.
Yeah, thank you. We have another questions related to rehabilitation services. So Dr. Mansi want to ask, can you please guide us regarding rehabilitation process on a large scale in terms of mental health and respiratory rehabilitation? If something New York is doing on that area.
Yes, another very important question, and please forgive me. This will have to be my last question because I have to run to another obligation. But again, I'm sure there are things that we can learn reciprocally from all of you and the Indian experience. We have, we've kind of put this under the rubric of what I call the parallel pandemic. There are the direct effects of COVID-19, and then there are those reverberating effects that I spoke about before. Mental health, substance use disorders, and long COVID, are all elements of those parallel pandemics. And so we have done a lot to invest in, mental health resources, making mental health care much more accessible. And particularly, for people who I think maybe never thought of themselves as having a mental health issue or mental illness, recognizing that it is something that affects all of us, and really trying to leverage that, sort of that public mindset shift that has occurred to call for greater investment in mental health systems for the long term. So those are some of the things that we're doing, with respect to mental health and substance use disorder as well. And then for long COVID, I'll just mention one thing, which is, there's a lot that remains to be elucidated scientifically about the long-term effects of COVID-19. So our approach to this has been a combination of supporting that scientific investigation, really understanding, the effects. Some of them are neurologic, some of them are psychiatric as well. But also providing some immediate clinical resources. So we've invested in what we call, COVID centers of excellence, which are really dedicated to that 10 or 20 or 30% of people who have been infected by COVID-19 and have longer term symptoms. So that gives us sort of a place to converge both the research aspect of it and the clinical practice aspect of it.
Yeah, thank you.
I'll just take the opportunity to say thank you again. I hope some of this was valuable to you. I want to just extend again my very sincere empathy, in terms of what's happening right now. My heart just aches as I read, the news accounts and hearing from my family members as well. If there's anything else that we can do to support you in your urgent and important mission, please know that we're committed to that.
Yeah, thank you very much. And we have more questions, but we'll like to stop as Dr. Chokshi has to go. So I take an opportunity to invite Dr. Mavalankar for providing closing remarks and vote of thanks.
Thank you, Dr. Apurva. First, let me thank Dr. Chokshi for his insights of how New York City managed pandemic and lessons which we can learn. My thanks to Kim, Knowlton, and the whole NRDC tirelessly worked to put this together. Who put together this in this series of 1 year finishing of COVID pandemic globally. And I'm sure all of you learned a lot. I'm sure there are more questions. At a different point in time, we will reconnect with the people in New York to understand, and also to understand from other how they have dealt and how we can learn from our people who are valiantly offering it. Thank you very much. Thanks to everybody. Kim, if you want to add anything.
You've said it all, Dr. Mavalankar, and very graciously. Thank you, everyone, and our hearts are with you through all this. Thank you, everyone, for being part of this.
Thank you very much. Close the webinar.